Okay, good afternoon, everybody. We'll make a start. Happy New Year to all board members and our colleagues watching online. I'd like to welcome everybody to the meeting of South West London ICB Board. I'd like to particularly welcome Dr. Masood Ahmed on my left and Anne Rainsbury, who unfortunately has had to give apologies today, who have been appointed to the board as non-executive members. And also welcome to Hannah Doody, who has been appointed as our new local authority participant, and this is their first public board meeting. Welcome. Under statutory guidance issued by NHS England last year, ICBs are required to appoint a deputy chair of the board as well as a senior independent director, and I'd like to thank Jamal for agreeing to be the deputy chair, and to Anne for agreeing to be our senior independent director. As I think you'll all recall, last autumn, Sarah announced her intention to retire from the ICB, and I'd like to thank Sarah on behalf of the board for all of her hard work, dedication and commitment to the ICB and to the wider ICS over the last 8 years. I'm sure you'll want to join me in saying a big thank you to Sarah. They smell lovely. This, just a reminder, the meeting is being broadcast online and recorded. The recording will be uploaded onto the ICB website after the meeting, and a version with British Sign Language will be produced and uploaded too. Can members remember to use their microphones for speaking for the benefit of people at the meeting as well as for the recording? A hearing loop is available should anyone need it. As a point of order, this is a meeting which is being held in public, not a public meeting. And just to let you know, there is a fire alarm test at 2:30, which will last for approximately 20 seconds. If the alarm sounds at any other time, please leave the room through the emergency exit. Questions from members of the public will be taken at the end of the meeting. Any questions received in writing will be prioritised over any requests, but we will endeavour to answer any questions from members of the public at this meeting. We've received apologies from Councillor Andreas Kirsch, from Matthew Kershaw, from Jacqueline Totterdell, from Anne Rainsbury and from Martin Spencer. The meeting is quorate, I believe, Ben. It certainly looks that way to me. Declarations of interest, a register of declared interests included in the pack. To reflect the fact that we have a number of new members joined the board, we are updating that and it will be posted online as soon as that work has been completed. Could I ask the board to note the register of interests? Could I ask members of the board if there are any additional declarations of interest that they need to declare in advance for this meeting? Good. Minutes and action log and matters arising. We've included the meeting of the 20th of November in the pack. Can I ask members whether or not they are content to approve those minutes? Thank you. We'll approve those minutes. And I can confirm that the action log has been updated and all actions have been closed. Sarah, if I could go across to you for a comment on the decisions made in other meetings.
Thank you, Chair. So we've had 2 meetings since the last board, one in November and the other in December. And as you can see, there were 2 items on each agenda. One was around the provider selection regime and the approval of recommendations from the representation panel. The other was around our response to the 10-year plan, which we discussed at board and then we have submitted on behalf of the ICB. And in December, there was an approval of 2 awards, one around independent sector providers and the others around termination of pregnancy services.
Are there any questions for Sarah in relation to that? No. Thank you. We'll move on to the Chair's report, and there's a written report which is included here. I'd like to particularly thank Callie Palmer and her team at the Royal Marsden for what was an amazing day that I spent with Regional Director Caroline Clark. Really inspiring, fantastic to see the daycare facilities, but also to talk through the amazing plans for the life sciences expansion at the Royal Marsden site in Sutton. Truly impressive. So a big thank you. I'd also like to thank all of our provider colleagues in the acute sector, mental health, but also in primary care. January is always a really tough time, and during December and over the last couple of weeks, it has been an enormously pressured environment for all of our services, with significant increases in flu and in other respiratory infections. And we know that the pressure has been really intense. So a big thank you to all of our colleagues for managing that pressure. Happy to take any questions on the Chair's report, but I suggest we move on to our first substantive item of the day, which is workforce. Karen, across to you.
Thank you, Chair. I'm going to be supported in the presentation by both Larissa and Melissa, who are going to join us. Do you want to come to the table, ladies? We've got some new board members around the table. Do you both want to just introduce yourself first of all? Larissa, do you want to start?
Yeah, I'm Larissa Page.
Just need to...
Haven't been for a while. It's been a year, isn't it, I think? I'm Larissa Page. I'm Chief People Officer, South West London ICB. Thanks.
I'm Melissa Berry, Director of Diversity, Equality and Inclusion.
Thank you. What you have in front of you is quite a big pack. You'll be pleased to know we're not going to go through line by line every slide, but we are going to take this opportunity to update the board on the workforce transformation programme that we have in place across South West London. We agreed that we would do that on a 6-monthly basis, so this is the next time that we're doing that. Just to say about workforce, I suppose, and we've had this conversation, it's a hugely important subject. We know that there are lots of people across organisations working on it. We work not only with partners across the NHS, but also across the integrated care partnership, so that from a health and social care perspective, that we're working on the workforce agenda together. We continue to make progress against our plan, which both Melissa and Larissa will just give you some highlights for in a moment. But we do know that actually our plan is going to have to be revised, because we've got not only the 10-year plan for the NHS that is due out in the summer, we've also got the transformation programme that South West London will produce as well. So this is a point in time we're expecting to update our plan throughout the year as we go forward. And then just one other thing to say is that a number of the schemes that you see in here, which are making a significant impact and really innovative, the funding is running out. So actually the piece of work that we are collectively doing is to think about how do we fund those in a more sustainable way going forward. But if I just point you to slide 29, I'm not going to go through them all. When we look at workforce across South West London, we are making sure that we are looking to make sure that South West London is a great place to work, and we've put down our purpose. So, this is about making sure that people have fulfilling jobs, that managers can have the skill and the space and the confidence to manage, but also in turn that they treat their staff really well. That we've become a magnet employer, so actually everybody wants to work in South West London. And we also know, Mike's just talked about the challenges that we have over winter and the dependency that we have on really good staff. We also know that the way that we need to work will change as we go forward as well. So making sure that we're completely being flexible about how we design our workforce of the future as well. The next slide just talks about our challenges, which I won't go through. They are similar to elsewhere in the system, both nationally and throughout London, in terms of the challenges we have with workforce. This year, though, we also have, because of our financial challenge, the challenge of making sure that our workforce is of the right shape and the right size. And there's lots of work happening across our trust to make sure that that happens. On slide 31, and this is the bit that we'll just give you some examples of, we have set a programme that has 4 elements to it in terms of workforce transformation. and we will just take you through and make sure that we give you an update on some of those things. We have provided lots of information so that we've got it as a foundation and as a guide, and if there's anything that board members want to pull out of anything they've read, then please do so when we come to the Q&A. But we'll just start with some facts and some figures about our workforce, Larissa.
Thank you. So I think it's slide 33 in your pack. I don't have yours directly to hand. But just to share some highlights of our current workforce demographics in the health space. So we employ 38,000 staff. Turnover and vacancy rates are reducing. Sickness rates have increased from this time last year. We're also seeing an increase in the number of people retiring. We know we've got an ageing workforce, which is why we're really focused on supply and attraction and reducing those barriers to entry and employment in the health and care space. So I'm just going to highlight some of the work that we're doing in relation to that, and notwithstanding obviously having to continue to support and retain the staff that we do have. So I think it's slide 39. So in 2024 we've delivered over 23 careers events, workshops, mock interviews, presentations and webinars at a system level to support our local community. Particularly proud of a piece of work in primary care. So we've got project-based work experience where 20 unemployed people from the local community were applied to participate in this programme. They attended a 5-day work classroom-based development session, 2-week project-based experience placement in a primary GP practice setting, and the feedback was really overwhelmingly positive, and people said that they'd recommend it to friends and family. We also have a further 40 people that we're going to be supporting in April in relation to that particular programme of work. We've also made sure that we future-proofed it so that we're able to meet the NHS's work experience quality mark in relation to this piece of work, but we're focused on continuing to upskill people in that space. I think it's the 2 slides on. We're working to continue to upskill communities, ensuring that people are job ready. Also working with providers to help make it easier for people to get jobs, so reducing those barriers to entry. So they're just a few of the programmes in relation to that, reducing those barriers for people to enter NHS work. And I really wanted to highlight on the next slide the work of the University of Roehampton in supporting care leavers that are interested in working in healthcare into apprenticeships. That particular programme, which was funded through the investment fund, the ICB investment fund, supported care leavers into this particular programme. The aim of which, I think this particular programme is for 45 care leavers to be able to enter nurse associate roles. I was having a conversation with Melissa the other day around the care leaver population. So we know they represent 0.5% nationally of people in the population, but in prisons, and this statistic blew my mind, they make up 30% of the prison population, and that's just looking at men. We're talking about the impact that has on families and women care leavers. It's really sobering. So we know we've got a lot of work to do in this space, and as anchor institutes we can make a real impact in relation to helping break the cycle. Incidentally, just this week in the ICB we've just appointed 3 care leavers through an alternative and targeted recruitment approach in Elaine's team. So just demonstrating if we do things differently, the impact that that can have. We're a small organisation and we're looking to do more. So we had 34 people that applied, 7 people that were shortlisted, 3 appointed, and the other 4 we're going to be supporting through work experience. However, so we know unemployment rates are increasing across the country, and that's been a continuing trend since June last year. And we undertook a number of outreach conversations with people in South West London, and they've indicated that they would actually like to work in the NHS. They see it as a desirable employer. But also deeper insight shows that people want not only good work, but they want work-life balance as well. So we've got work to do around flexible working as well as employability and helping people increase confidence in this space. If I go on to the next slide, we can see what's happening in terms of our vacancy rates. So our vacancy rates are decreasing, but we still have an abundance of roles across the ICS where people can be recruited into, where we can continue that targeted outreach of supporting the right people into the right jobs. So essential work, especially when we revert back to what I said at the beginning, that we've got an ageing population, so we really can't take our foot off the pedal in relation to this. Retirement is the top reason why staff are choosing to leave South West London, and that's closely followed by relocation and work-life balance. So the transformation work that we've got in this space to do, really significant and important. I'm going to move on a couple of slides now onto retain. I just wanted to just talk about a couple of bits that we're doing around retention. So since August 24, we've seen sickness levels increase in most staff groups. That's true across the country as well as across London as well. And we're consistent in London in terms of where we're tracking. But mental health has the highest rate of absence nationally. In London, nationally it's 25%. London, it's 18%. We're 17% in South West London. Burnout and work-related stress are the main mental health presentations. That was as of data from October. That's 8,712 days lost in a month, just to help focus our attention. We have mental health and wellbeing hubs in South West London. We've got 3 access points. And in terms of people presenting, the things that they're presenting with is of stress, personal stress, again, followed by work-related stress as the main reasons for referral. I'll go on to the next slide. So we're trying to innovate and be targeted in this area in terms of supporting men and women's health, and we're using data insights to help us with that. We know that staff want better work-life balance. They're looking for flexibility. I think it was about 18 months ago we were approached by NHS. We had 2 trusts in our patch who had really high turnover from a nursing perspective nationally. And they were trying to understand what we were doing in that space. We have seen improvement in that area, but we know flexibility remains something that's really important for our staff. So we needed to look at workforce changes that can be made around rostering, how we can do things differently. So we're working with the Capital Nurse programme to look at more flexibility in the ward area and ward settings. I'm going to hand over to Melissa at this point.
Okay. Thank you, Larissa. So I'm going to start by talking about the System Leaders Programme. So I did talk to you last year about the System Leaders Programme. We had managed to attract some funding, which we created a System Leaders Programme, which is really to look at our representation across the system. So we know as a system, we don't reflect our, as workforce in senior levels, we don't reflect our patients. So part of that was about creating a System Leaders Programme. And how we did this initiative was different to what you normally get. What you normally get is initiatives that are either focused on the global majority, so black and ethnic minority staff. This initiative was different because we had 30% of the staff who went on this were from white backgrounds. And so what that meant was actually we had much richer conversations. We really focused on how people become really good system leaders. We had Dr. Eden Charles, who ran the programme for us, which I know some of you know, and he's been involved in some of the work that we've done across the ICB. All 20 of our staff have gone through. Five people from the programme so far are in more senior roles, because the ambition of the programme is the people that go through the programme are in a more senior role in the future. We've got a number of people who are mentors, sponsor mentors in the room. So Mike's one of them, Jacqueline and Gillian are both one of them as well, and we are going to have cohort 2. So the programme actually, when we launched it, I remember, because Sarah and I went, Karen went along as well and spoke. So we've had many speakers, including Ben actually, because we... Not saying that you shouldn't be there, but it was really good to have Ben come along. And the reason why I'm highlighting that is because many people who want to be senior leaders haven't had the opportunity of being exposed. So, i.e., coming and presenting to the board, understanding what the board does. So Ben's session really focused people in on thinking about governance and how you'll work as a system leader. We will be running that programme again. So we have a cohort 2 of that programme, and Karen noted about funding, and so that's something I think I keep on constantly talking about, is that I've been really good in the past of attracting external funding for us in South West London, but we know those pots are drying up. So that conversation about how we fund things that are working for us going forward is one that we are definitely need to be having. So I just wanted to highlight that about the System Leaders Programme. And then I can't even see where I am on the slides, but I'm going to talk about them as they come. So I'm assuming everybody's read the pack. But the Ask Auntie initiative, which is a great initiative, which I think is one that we really need to celebrate, because we have managed to get 250,000 from NHS England when no funding is being given out for equality and diversity at all. So that is no short feat. So we've got two programmes at South West London level that that are going to be scaled up for London. So as of January this year, the Ask Auntie programme is going to be scaled up for London. And really what that is about is, I was talking to Charlotte earlier, but how I was describing that to her is that we have a lot of staff that come from overseas. And ultimately, if you think about, I moved from Birmingham to live in London, and I was like, wow. So if I've come from the Philippines or India, this is a big city to now be living in, navigating. Where do I get my food? Where do I go to pray? All the things that we take for granted because we're already here, we're already part of the community. And what we can see is that when we have people that come over from overseas, generally they leave us after the 3 years and go somewhere else. And that's because they haven't had a good experience. And also what I was sharing is that the global majority, even though they might sometimes be coming from Commonwealth countries, have never experienced racism, don't know what that's like until they live here. And it's really important that we create something where we, part of the part of the Ask Auntie is around peer mentoring, support, being able to build relationships, simple things as being able to show someone where to buy their local food, where they can pray, all those things that mean a lot to people in their working environment, because generally people come over, we give them loads of support in the beginning and then we kind of leave them, but we want them to stay, we need them. The NHS is built off that basically. So I think what I was saying when I was talking to Charlotte, what I was saying to her, it's really important that we're celebrating these initiatives that we have in South West London. We should be shouting about them nationally because they are great initiatives that we have. So if anyone wants to talk to me outside about that initiative, and there is also an app being developed so that we can mobilise that across the whole of London, so all 5 ICBs will start to benefit from that work. And then the next on my list is to talk about the Disability Advice Line. So the Disability Advice Line is also something that we've piloted in South West London. And ultimately, the way I would describe that in its simplest forms is if you have somebody working for you who has a long-term condition or a disability. Sorry, do you want to... If you have someone who has a disability or a long-term condition, we're able to support them properly, because we know as a system that we end up spending significant amounts of money when we don't put people's reasonable adjustments into place. So what we've done is try to create a central fund where instead of waiting 6-7 months for Access to Work to give us the money, we will make someone's reasonable adjustments, because in the past we've had staff members who've sat at home for a considerable amount of time, and that doesn't help with our retention piece, doesn't help with sickness absence, and also is a place where people can learn and share. We've helped over 100 members of staff so over the last 12 months, and we've also been able to get £30,000 back into the system from Access to Work. And so what was happening previously is we weren't getting that money back because it was taking such a long time. So with the advice line, the people that we've got working for it are now claiming that money back. So that is good. And also the piece of work that I'm doing with the finance directors is to look at how much we've spent out in the past in employment tribunal, what that means in terms of staff cost, and then there's the moral compass of the reason as to why we're doing it. So also being able to show that that's a value to the system and we should keep it. And London have also talked about potentially next year funding that so that it's upscaled to a London level as well. And then I've just got one more that I'm going to highlight, which is about our anti-racism work, which, gosh, it's been one of the hardest projects I've ever had to take on because the scale of what we are trying to achieve, we're actually trying to be really ambitious with our programme. But we need to remember that racism is a construct and has been around for more than hundreds and hundreds of years. So we have two partners, so we've worked quite heavily within the voluntary sector. So Sarah, thank you for all your help in getting out to the voluntary sector. So we've been working with the voluntary sector on engaging them. We've got a grants giving process, which we're currently doing at the moment between now and March, and that will be to test the racial insights and also our product around an anti-racism toolkit framework. We haven't quite decided what it's going to be called with the voluntary sector, and then there's still the work around flare impact, which we have been delayed on, but we will be starting that shortly. And what I would say is we've also been heavily linked in with all of the work in the Mayor's office as well. So all of the work of the Larch, we are looped in all the way through in the work that they're doing around anti-racism. So making sure that we're bringing all of our partners along to achieve that. And the way how I would describe it is that and when I was writing something today, is that we want a system that feels like an anti-racist place to work. So that's me.
Back to me.
Yeah.
I'll be really quick. I know there's a number of people around this table, all senior leaders are really committed. Oh, sorry. I keep forgetting to do that, sorry. A lot of senior leaders around this table committed to needed transformation to support our workforce and make us fit for the future. In fact, it was this time last year that we discussed needed transformation and comments made by individuals here around that we need to create a system-wide programme that develops our middle managers to be more inclusive, which you, James. And we took up that challenge. We socialised that idea with L&D teams across the different provider organisations, just to ensure that there wasn't already something out there that existed in that space, to ensure there wasn't any further duplication. There was no duplication found, and it was warmly received. So on the back of that, we commissioned the University of Roehampton to partner with us and co-designed a master's level short course. The first cohort, 35 people, actually we had 63 people apply, 40 that were accepted. We had 5 drop out, unfortunately, but 35 completed the course in December. And we'll shortly be promoting for further people to come forward for cohort 2, so for a further 40. But it was really well received, challenging for those people that were on it. It was a real experience. I'd suggest that you look at some of the quotes that people have shared with us on the following slide in the pack, but more to come on that. And last but not least, I just really want to talk about apprenticeship. We know the importance of apprenticeships going forwards to help in securing our future workforce. We've created an apprenticeship hub through the investment fund to improve understanding internally. We know there are real barriers to achieving this. We only receive, I think we set ourselves a challenge of 10% improvement in apprenticeships for last year. We didn't quite meet that target. We're a bit below than we would like to be. So we know there's work to be done in this space. We need to improve understanding internally around what apprenticeship is. It's not the old YTS scheme. There's still people that still have that view. So more promotion needed, and the hub is helping with that. And they're also really helping with the foundation of work to ensure that organisations are well placed to be able to support apprenticeships of staff internally already working in the organisations, but also bringing new people in. We had an event, I think it was back in September, just to understand what are the challenges from different partners, education partners, if you're an applicant looking to come in to be an apprentice, what challenges are people experiencing, so that we're really focusing on the right areas to help move the dial on this. I think that's probably all I'd like to share. That's a bit whistle stop, lots to say. I'll hand back to Karen. Thank you.
Thank you. So just to finish then, so what it's difficult to do justice, as Larissa just said, to such a wide programme, but what the programme at South West London is trying to do is to support organisations both in the NHS and beyond to attract, retain, develop and transform workforce, so that actually we've got the right staff that are able to support citizens and patients going forward. So we hope that the written information and then some of the things that both Larissa and Melissa have brought to life just share with you some of the progress that we're making, but ask you to note the programme and its developments, but also happy to take any questions that you have.
Thank you for that, and that's really impressive, and so many good projects there. Just amazing to see that we've already supported 800 apprentices this year across South West London. And you know, we're looking to spend close on £4 million in that area, which is transformative in terms of the people. Got a whole host of questions. I'm going to go to Callie first of all.
Thanks very much, and a lot of excellent and interesting information there. So I just wanted to press you a little bit further because there is so much. And I guess my question is around, so there's a lot of statements about where we're up to with the workforce, then some great information about new initiatives, which is fantastic. But I suppose what I was struggling with, just as a board member, is so what are we trying to deliver this year? I know workforce is a long-term programme, but is there a delivery plan that says this is year one, priorities, funding, delivery, year two, year three? What I couldn't do was sort of work out when we get to this point next year, have we done a good job against all the things you set out to do? So I just wondered if there's something that chunks it up in a way that the board can see. And it may be that's a different document, a delivery plan, but and completely understand that workforce is a huge issue and it's pretty long term, many of the programmes, but I just wondered about that.
Before we come to that, I'll take a couple of other points. Not everybody, but I will come to everybody. But I'll take Masood, and I'm working my way along. So. Masood.
So a comment and then two questions. Firstly, amazing, I think, the fact that you've been so proactive, practical, and also getting funding in this environment, really well done. Especially the Ask Auntie, the disability advice line, and the fact that you kind of gave the context that, the value being delivered is the fact that we're hopefully not going to employment tribunals, etc., for things that we could avoid, and the anti-racism work. The questions, with the health and well-being side of things and the mental health hub, you've given a lot of numbers about utilisation and the fact that, almost 50% of the activity is due to stress, whether it be work or personal. How are we assessing the impact of those services? So what difference is it making? So that's the first question. And the second is really whether we've considered, in terms of the context of the cost of living crisis, are we doing anything around salary advance? Because if you look at a number of our staff, sometimes the issues are about timing, and with those that are most vulnerable, if they're having to go elsewhere, the impact of that. And sorry if I've missed it, but are we doing anything around salary advance?
And I'll take one more, but on that last one, we might actually have some trusts that want to say some of the initiatives they're doing in that space. But James, you didn't have your hand up. Sorry.
No. I'll come in.
Do you want to? Yeah. Do you want to come in on the? Well, because I think that you're one of the trusts that's doing something on the
on anti-racism. Yeah. So we are taking forward the Ask Auntie programme, and just within Epsom and St Helier we have people from 78 nationalities within our workforce, and we know that that actually, as Larissa and Melissa said, getting people to stay after 3 years initially within the country is about how we manage to support people to sort of feel integrated and part of the community, and it's made a huge difference. But also for us around workforce race equality, we have seen a significant improvement around our workforce race equality standard, and that's been about tackling the cultural things, but also backing it up with some really definitive changes to policies and procedures, particularly around how people enter into disciplinary policies, because we had a massive disparity in white and non-white people entering into disciplinary policies, and we've completely changed the gateway into that process, and that disparity has just gone away. So I think that there is something about supporting people in terms of setting the right cultural markers within the organisation, but I think you actually have to back that up with really solid HR practice. And back to the points about middle managers, it's incredibly encouraging that we've managed to get that programme in around middle management, but it feels like it's more and more of a challenge. And as we move towards regulation of managers, we're going to continue to need to really focus on that middle management cohort in terms of giving them the skills and the competencies, but also the tools and the policies around them to be really effective in their jobs, because I think their role has become more complex and difficult than it ever has in so many different respects. So yeah, absolutely, Mike, that's something that we've really taken on as a challenge, and we've, you know, through a number of things, been, I think, able to really shift the dial for our own organisation.
Great, thank you for that. So Larissa and Melissa, do you want to say anything in terms of responses to the questions before I take another round of questions?
Yeah, thank you very much. I'll respond to Callie's point, if I may. So this work isn't happening in isolation. It's seen as or in a vacuum as a nice thing to do. We've been trying to be quite strategic about our approach to this to ensure that it aligns to, for instance, the joint forward plan. So it's our workforce strategy for the system, and then also our the ICP delivery plan from a workforce perspective. So elements of work will maybe link into those two pieces of strategy. So there's a delivery plan over the next 3 years, I believe, for both of those two strategies. So yes, it does link into those things. What I will say, some of the work that we're doing is impacted, we mentioned this at the beginning, by funding. So we're looking at some of those programs now in terms of, you know, how do we make them sustainable if funding is drying up. We know it's challenged at the moment, and they are the things that we need to continue with. How are we going to do that? But, yeah, so hopefully that responds to that point. In terms of health and well-being and the impact, yes, so again, we've got to be data-driven and insights-driven. We are evaluating the money that we're investing. Again, money is drying up in that sense, in that area too. But we are evaluating to ensure value for money in the services that we are offering. So if I was just to feature the footy talks, it's not large members of staff, it's deliberately small. We know that men generally don't tend to talk about issues in relation to mental health, so linking it with something to do with sport, it seems to have a really great benefit in helping people to open up. I think it's about 12 people, I think it's 6 aside. I think it's about £130 for that session. We know that's much less than it would be for a counselling session. So we're always evaluating, are we getting value for money in the things that we're doing? The mental health and wellbeing hub is reviewed on a monthly basis in terms of how many people are we getting coming in, what's the makeup of people that are coming through, are we utilising counsellors and psychotherapists rather in the best way to ensure value for money. The cost
Apologies. I was talking more about the impact on the individual. So for those that are struggling,
yeah.
Is the outcome that actually we get them back to work earlier, and so, you know, that sickness rate, that's what I meant. But thank you for that context.
So just to speak to that point then, the idea is about preventative support, so getting people before they go off sick. Obviously there are some people that are off, and there are various other services in-house in provider organisations to support those individuals. Employee assistance programmes, a lot of provider organisations here have those, as well as occupational health departments as well. So the transformation work that I'm talking about is more preventative in nature. So I hope I've answered your point there. The cost of living point that was also made around salary advance, really good point, and that's a conversation that we have had previously. That's something that individual organisations would be picking up directly to support that. We know that if we do that, we need to be really mindful that people aren't going into further debt, and that's part of the conversation that we've had previously. I don't know if colleagues around the table are able to respond to that point.
I mean, I know certainly some of the trusts have got salary advance schemes, or basically you claim your salary up to, but you get it paid quicker than if you wait until the end of the month. Vanessa, did you want to? I think you've got a scheme in place at South West London St George's.
Yeah, we have a scheme in place at South West London. Staff can draw down the monies, but it's very thoughtfully done in terms of ensuring that people don't get into further debt. And we also have a cost of living hub that sits alongside. So we look at the underlying issues, and then our employee assistance programme can then further support our staff in thinking through effectively their financial their financial position. Just in terms of the mental health and well-being, as I've got the microphone, really great to see these preventative measures. We need to remember they're preventative measures as they're not evidence-based treatment. So they may support people with mental health and well-being. They are not treating mental illness. So just so that we're really clear in the difference. But excellent work.
Thank you for that. I'm going to take a few more points. So working down this side, I've got Shannon, then Jamal, then Jeremy.
Thank you. Just 3 quick points to mention. The first one was around the equality and diversity inclusion profile on the staff. And it's a question related to the delivery plans, because I just wondered what the aspiration was in terms of, you know, where you'd want to get to in terms of that representation of global majority staff in the more senior roles. And then the second point, which is related to that, was whether any sort of qualitative work has been done to try and understand the reasons for some of those gaps. I think some of the reasons might be obvious, some of them might be less obvious. And whilst I note all the good work, for example, the leadership programs and all of that, that kind of takes a deficit approach with a hidden assumption maybe that, you know, people need to do more in order for them to be in those roles, rather than, you know, looking at the fact that there might be people who are actually already suitable for those senior roles from global majority, and what is the reason why, you know, they're not getting into those roles. And then the last point that I just wanted to mention was around the health and well-being, and like, you know, everyone else, I really welcome all the preventative approaches that are being undertaken. And my question was whether there's been a consideration of taking a whole systems approach in terms of looking at the NHS as an employer in terms of developing a health promoting environment. So not just thinking about people who might already obviously need some support with their health or their physical health or their mental health, but actually thinking about the workforce that is already healthy, and how the whole system, everything that the employer does, can support people to promote and maintain that health. Thank you.
Thank you for that. So Jamal.
Thank you, Chair. And thank you for the presentation. Really, really insightful. I think it's a big agenda and lots of initiatives which I support. And because it's a big agenda, I want to focus on one thing, which is turnover, if I can. And just trying to understand some of the root causes. And I know you've got a table here with reasons for leaving. And I'm particularly interested in one or two that seem intuitive but are not on that list. And it may be covered within the other not known reasons. But if you look at reasons that, if you look at national surveys on workforce of why people leave, whether it's the LinkedIn National Survey or the Reed National Survey, one of the biggest reasons why people leave is line manager relationships and culture and communication, you know, personal development plans. It's all around leadership. And that seems to be missing for me from this table of reasons. And I wonder whether it's exit interviews or whether you've got any insights around whether that's my intuitive experience throughout my whole life. And any surveys that I've done historically, I think 57% I saw somewhere in LinkedIn was the line manager relationship is the reason people leave. And we've got 5,000 people leaving at the moment. I just wondered whether that's and if we don't think that is an issue, then we won't do anything about it. So I just wondered whether you had any insights on that.
And I'll take Jeremy, and I think on this side I've just got Nicola, and then I'll take Nicola, and then we'll take your final comments, and I'll hand over to Karen for final words. So Jeremy.
Okay, so thank you. I really welcome this report, really comprehensive report. So just had two particular points to make. Really welcome to hear the joint work in terms of the adult social care workforce joined up with health. And I think particularly on the attract priority, there's some real benefits about working together across health and social care, particularly because people don't always understand what social care is, but I think they'll understand more in the context of looking at the whole system. And that's really good examples highlighted there about the graphics and social media. So I'd be keen to probably connect with you because I lead on the social care workforce for South West London. And then the second point is really just in terms of how local authorities support their own residents and people with ill health into work. I know we're working on it's called a Connect to Work programme, and there's probably opportunities to join up our work. That's about getting residents who are in poor health into work. And of course the health sector is a big employer. Thank you.
Great. Thank you. Nicola.
Yeah, thank you. It's clearly massive amount going on, but I was just thinking about the numbers. The commonest reason why people leave is retirement. And whilst you're doing a lot on retention, and I think retention is probably a more cost-effective approach in general than attracting new people and developing them in the building. You know, there's kind of a lot you can do there. Whether you might think about a sort of focused programme for different groups to look at retirement, because I know if every GP out there and every practice nurse out there all stayed an extra 2 years, my goodness, we'd be in a good place. That would be a really great thing to happen. Just a thought, really.
Great thought as well. So, Larissa, Melissa, if you've got some final comments on those points, that would be really helpful.
Yeah, so in terms of the representation and setting targets, we actually haven't done that. The baseline that we have is currently very low of what our representation is, 8C and above. And maybe I didn't articulate it well because when the programme isn't to create a deficit model, because I am a believer that generally global majority staff are mentored, they go through programs all of the time, and that was the point of having staff who were not from the global majority as part of the cohort as well. That's why we created it in that way. And I guess what I liked was in some of what you were saying is it's almost challenged, because if we want to set that target, we can. I think that's a good thing, but we need to make sure we can achieve it. And a lot of that is, you're right, the people that are in that cohort, they're ready for the next step. Is the jobs out there for them to go into? And also, are we ready to have our rooms looking more diverse? So a lot of the times is when you read about the narrative is when we have more board members from the global majority background. What is their experience on the board? Do they stay? How do we support them? So a lot of the programme also is about not just them getting into the job, but it's also how we support them going forward as well.
I'm probably going to take all the different responses that I've had in public. Sorry, I keep forgetting to do that. Sorry. And pull them together. So looking at health and wellbeing in a health promoted environment, reasons for leaving. We know most people leave their manager more than they do the organisation. I think they are hidden, actually. I think that it comes up quite often under other reasons for leaving. Sadly, we don't have that level of information at a system level, but in the provider organisations around the table, they will have that level of detail. Through their exit interviews, I think a number of organisations use Great with Talents and Organisation to help collate that information. When we think about the connect to work and flexible working approaches to keep people in work, so looking at those potentially looking to retire, all of this comes back to the environments and the management support that people receive in the organisations that they work in. So it is looking at it through the lens of inclusivity. Thinking about those that are maybe older people that are looking to want to work, connected to work programme, people that are currently disabled or off on long-term sick leave or have been out of work for a long time. All of these things are contingent upon having a supportive manager that is happy to allow people to come into that space, to support them and to be flexible to enable them to continue to do the work, and also to develop them to do the work in a way that meets the work that's required in a way that they're able to do. All of this is about flexible and supportive and inclusive management. There are things that we can do at a system level, but there are things that are happening within respective organisations around the table that we don't, again, want to duplicate that effort. So there are existing development programmes within organisations looking and seeking to support the capabilities of managers working within their organisation. So what we're looking to do is enhance that. Areas where there is deficit, inclusivity is a real issue. To create a space where all people can thrive. So they're the areas that we're focused in on, but happy to find out from each individual organisation what they're doing in this space and share that learning at a future meeting.
Great, thank you. Karen, final comments.
So I was just going to make the point that Larissa just made. I think that Action for Workforce sits across every single organisation, and we're doing things that make sense at scale. But it may be that for future board meetings, what we want to do is to hone in on one aspect and think about that not only from a system perspective, but also organisationally, what's happening and what are the actions. Because, I mean, things like workforce race equality, the review of that across South West London, we can take a different approach. We know that organisations are already doing lots in that field as well. So I wonder whether actually in future we want to think about maybe topic specific and bring in both what's happening at system as well as what's happening at organisational. But the comments and the questions are really helpful, so thank you very much for that.
Thank you. Thank you both very much for both your presentations today, but actually your hard work in this area. It's really, really appreciated.
Thank you. Thank you.
We'll now move on to the update on the South West London Acute Provider Collaborative. So this is our second in focus item for the agenda. And I believe, welcome Susan. I believe Susan and Joe are going to jointly present this, so I'll hand across to them.
Brilliant, thank you, Mike. And so Susan and I are going to do a bit of a double act. For those of you who don't know me, I'm Joe Farron, Chief Executive of Kingston Richmond NHS Foundation Trust, and we're very much part of the Acute Provider Collaborative. And you might recognise Susan from our last meeting, actually, where she was presenting an item around the cancer strategy. So we've just been really lucky to have Susan with us in an interim capacity as our Managing Director for the Acute Provider Collaborative, and she's helped us move things along really quite well, and we'll say a little bit about that this afternoon. For those of you who don't know, the Acute Provider Collaborative involves all the acute trusts in South West London, so Kingston, Epsom St Helier, St George's and Croydon, and we've got a long track record of working together in collaboration. Probably pushes it a bit, but you could stretch it right back to Swellyock, where it all began. I'm not sure I'd quite go that far back, but we've been working really closely together for many, many years, and we have a number of examples of formal partnerships that we've formed around both corporate and clinical support services, as well as more recently, particularly during and post the pandemic, areas of joint endeavour, whether it's around diagnostic access, outpatient redesign, elective recovery, the transformation work that we've been doing in conjunction with our clinical networks around clinical transformation, as well as further alignment of our corporate services. And what we wanted to do this afternoon is share with you a little bit around the progress that we've made over the last 12 months or so, which we are really proud of in many, many areas. It's always quite good to take a bit of a step back and view where South West London sits on a number of markers against other parts of London and indeed nationally, and also think about the part that the Acute Provider Collaborative has had to play in supporting all of that. And Susan's going to take us through some detail in a moment, which will provide some credentials, and then what we'll also do is shed a bit of light on our current areas of focus and our thoughts around what next year could look like, recognising though that we're still waiting the planning guidance and we're yet to work through our planning cycle. And then, we'll have a bit of time for a few questions, no doubt, at the end of all of that. So without further ado, I'll hand over to Susan.
Thanks very much, Joe, and thanks, Mike. Good to see you. So I think the three areas that I really want to focus on today are very much aligned to both the what we know is coming out in the new NHS strategy and the document that was published last week, the elective reform plan. And it's really three areas where South West London is focusing on step change to redesign pathways. And a fundamental part of all of the things that we do is really about supporting inequality. And I think that's really in a twofold approach. Firstly, to understand better where the inequalities are, and then secondly, to design and redesign services to make sure that we address and stop inequalities in our care. The three areas I'm going to focus on are the implementation of our community diagnostic centres, the delivery of and embeddingness of technology, and the approach we're taking to reducing waits across South West London. So community diagnostic centres were really funded as an outcome of the COVID pandemic, and I think aim to do two things.
firstly, make sure that there was more diagnostic capacity available, but secondly, make it much, much easier for patients to access that, both in terms of location, but also in terms of pathways that enable GPs to get a diagnostic opinion without needing to refer to secondary care. And in South West London, we have really focused on implementing our CDCs in our more deprived areas, and for that reason we will have 2 by June 2025 in Croydon, out of a total of 4. And that has given us a real step change in the amount of capacity we have. It's allowed us to deliver 725,000 scans and tests over the last 3.5 years, which is about 26% of our additional diagnostic capacity. And I think just in terms of how we're doing compared to others, the South West London CDC programme is responsible for about half of the CDC activity in London. So I think this is something where we feel we've done a really good job in terms of getting the infrastructure in, setting up new and novel pathways. We've got, for instance, a respiratory hub based in Purley, which we're testing, and then we can spread to the other CDCs. And really, excitingly, we're also reducing our waits, and we know that when we think about the 18-week constitutional standards, getting diagnostics done quickly is pretty fundamental to that, and you can see some of the data there. Moving forward, I think our approach to CDCs will be very much to understand how we can fulfil the commitments within the elective reform plan, particularly around 8 till 8, and continue to focus on extending access to direct access in primary care, which we know supports earlier diagnosis of a range of illnesses. In terms of technology, I think our aim here is pretty ambitious. We are aiming in South West London to allow as many patients as want to manage their care as much as possible through technology, but also noting that for many people this isn't possible either because of disability or because they are digitally excluded. And what we really think we'll be able to start focusing on, with resource freed up by some patients managing things via tech, is that we'll be able to support more support for the core 20 population moving forward. Our approach in technology is firstly about supporting prevention and secondary prevention, and we have a very well validated app called the Get You Better app that's not just for South West London. We have 19 pathways live, and 42,000 people have been signposted since April 1st on that. What we want to see is real reductions in primary and secondary care consults, and obviously less prescriptions. And I think over the next year, really scaling that up and making sure that we're using that in a very, very focused way will help, not just in terms of avoiding short-term problems, but in terms of long-term prevention. You will have, those keen readers that have read the elective reform plan will be aware that there's commitments about having patient portals to communicate where people's care is up to, that interface both with the EPR systems, the electronic patient records, and the NHS app. And South West London actually has procured a single portal across South West London, which is in play in 3 of the trusts so far. Epsom St Helier is not yet using it because they're focusing on putting in their new EPR, and it will connect automatically once that's bedded in. But yeah, I think the buy-in from patients for this really shows how much we're knocking on an open door in terms of people wanting to be technically able to support their health. And we have 73% of those invited registering with the app. And at the moment, we've been focusing on making sure that it's easy to view appointments and test results. But I think moving forward, I think we see real, this is a really important part of architecture that starts changing the way we deliver care. And so we've got some examples here of some of the questionnaires, but if I give you an example of the different ways they'll be used, in pre-assessment, this will mean that patients don't necessarily have to have a call either virtually or face-to-face prior to their operation. They can be assessed and fill out their questionnaire, saving patients time. We also have areas where we know that using questionnaires to record symptoms and symptom onset will make a really big difference to the way that we manage and diagnose care in secondary care, and that would be in something like neurology or rheumatology. So I think we see that once we get these first 19 pathways, this will become very, very normal to support patients, with again that caveat that for those that can't do that, we make sure that they're running to same timeline support through clinical or administrative contact. AI, I think, is becoming far more than a buzzword in health. It is something that we know will make a really big difference, from things such as helping radiologists analyse scans, but also fundamentally change the way that we can manage care and release time to care. And I think one of the programmes that we're most excited about, that we've done a very at-scale programme and pilot in both Kingston and St George's, is the use of ambient AI in outpatients. What that allows the clinician to do is have the consult recorded in the background, delivering the outcomes of the clinical appointment without the clinician having to constantly sit on their computer telling, and typing rather than looking at the patient. But I think once we've established the clinical accuracy of that, and really at this point we're testing it in lots of different clinics to make sure it works as well as we hope it does, the opportunity to fundamentally redesign outpatients, to have a patient leaving with a good summary of what's happened that they can use as an aide-memoire and to move on their care processes is really significant. So for that one, we are all watching eagerly, with the aim of spreading and adopting as quickly as possible, and really looking to use this not as an adjunct but as a complete change in the way we're supporting patients. Two other cases in the way that we're really embedding technology across South West London. One is that we use it very much to create platforms that allow clinicians to work in a very standardised way. We have a really great collaborative working team within the medicines teams across South West London, and that's enabled their single medicines formulary that they've created to actually be put on a technological platform, meaning everyone's got instant access to any changes, and that's really supporting standardisation. The final area where we're more and more excited about the technological abilities is in data and analysing waiting lists and so on. And I think one of the things we're doing in partnership with our ICB colleagues at present is looking through all of our waiting lists to make sure that we don't have inequity by different core 20 or other protected characteristics across those. Because I think what we want to make sure is that we, as we're starting to really restore the constitutional standards, we're doing so in a way that eradicates any latent inequality and make sure that we actively address any issues that are causing that in our pathways. In terms of reducing our overall weights, we are pretty excited about our performance here. We expect to have no 65-week waiters by the end of March, which is a huge achievement. And we're working to under 100 patients by the end of January. So I think, a really big achievement from our hospitals, very much supported by the single PTL that we're using. Our 52-week waits are the lowest in London, and they're fairly static, but we are looking to reduce these substantially over the next year, but we're talking under 1,500. So again, compared to others, we're doing really well. We know that to reduce some of these weights, some of this requires quite a lot of additional activity, but we have been also focused very heavily on efficiency and productivity while we wait for the new funding formulas. So we know that in outpatients and theatres, these are two really big parts of the pathway that enable people both to receive specialist support and, in the case of theatres, actually often have an issue resolved. For outpatients, we've been using something called patient-initiated follow-up, and we've been driving increase of use of this through our 9 clinical networks, with 41,000 more patients on a PIFU pathway in the last year. And again, what that means is that we're starting to allow patients to make choices about how their symptoms feel, rather than bringing them back for a follow-up appointment, which may be completely unnecessary. We know that DNAs are a really significant issue in terms of waste, but also in terms of patient convenience. And obviously our app will help people get ahead of that and rebook appointments if they're not convenient. We've reduced this by 1%, which is equivalent to 2,000 appointments per month. But what we are doing is we design some of our single points of access in ophthalmology and in ENT, which will be supported by Kingston Hospital, is building into that programme a approach that ensures that the core 20 population are automatically contacted and spoken to about how best to get them into the service, so that we're effectively treating them as a high-risk population, because we know DNAs are higher in that population. And then finally, advice and guidance is something which really replicates care from about 40 years ago, where people used to just phone a specialist to get an opinion. Now, we went through sort of dark days of across the NHS where people would have to make a referral to get that opinion, and advice and guidance really allows that opinion to be asked and support given by primary care without the patient having to be made to be referred. In terms of theatre utilisation, we are really pleased with the work we're doing on this, and one of the things that we have got across the trust within the collaborative is a real focus on not just getting to a good standard nationally, but thinking about what the next thing is that will improve theatre utilisation further. But over the last year, we've restabilised theatre utilisation to over 80% on capped utilisation, which is a 10% improvement and pretty consistent now. With Swellyock, which is something that we've always prided ourselves in terms of efficiency, we've actually increased activity by 8% in the same time period to the year before, through new ways of working. And I think what's really remarkable about that is we've also managed to reduce the bed base through really efficient, focused care pathways. What all of that brings us to is a pretty good position, not where we would want to be, but we're well above average in terms of the 18-week referral to treatment pathway. And we are very keen to understand the planning guidance and how we will be supported to get to the 65 plus aspiration next year. I don't want to spend lots of time going through the clinical networks, but I think a few things just to highlight there. All of our clinical networks focus on both primary and secondary care. So in something like ophthalmology, we're doing an end-to-end review of that, which means that we're harmonising the community contracts, setting up points of care and equalising weights across South West London to make sure we have truly equitable treatment programmes. We're also doing a lot through these specialist networks to move care out into the community, which is a really big commitment. And I wanted to draw your attention to two areas. One is neurology, which I think we often think about as a hyper-specialist area that obviously needs secondary care input. But the neurological clinical network have moved significant amounts of care for very dependent patients out into the community. Subcut immunoglobulin has been started to be utilised for people with inflammatory neuropathy, and the impact on patients is very, very clear when I say that for every 5 patients, that's saving 400 day case admissions. So the amount of their life spent in hospital and what we're releasing, and we had a really impactful case study about what that meant to patients in terms of their social function. And we've also launched a domiciliary spasticity service, which means that for those patients with spasticity who need to come into hospital often to be treated, that's actually a big ask for those patients because it's very difficult to get them into hospital. And we've launched a domiciliary service using our existing physios and training them to deliver that treatment. In gynecology, we've been working very closely through the clinical networks, the collaborative and the ICB, and we're really pleased about the progress with our women's health hubs, and we're expecting the first one to go live in Q1 25. So I'm going to hand back to Joe now to give time for questions.
We're quite busy, as you would have heard, and just to say a little bit about where we're probably going to focus next, in addition to sort of carrying on progressing the priorities that Susan has just said a little bit about. Clearly, we need to reflect on the planning guidance as and when it finally emerges, and also get the detail of the financial arrangements that sit beneath the elective guidance too, because that should be an area of strength and opportunity for us, not just to continue to deliver really good care to the population of South West London, but also help from a financial perspective too, but that will need to be worked through. I think there's quite a lot for us to do, both within the APC and probably more broadly from a digital perspective. We've got some real opportunities around alignment of our EPR platforms, which will happen over the next sort of few years or so. Susan's mentioned things like the AI pilot that we and George's have been very much part of, that we're looking to take to the next level. And I think one of the things around all of that is also recognising our role in our places too. So we've talked about it at our place committee. I know colleagues in GPs, like primary care land, either have similar products or are very interested in the products that we have. So I think there's something about how do we use our infrastructure to support local development too. And I think there is a role, I was going to mention it on the workforce item, just a bit of collective thinking about where digital and tech plays into what we're doing on workforce, and probably across our agenda more broadly, because it's very easy to be seduced by a whole bunch of things that are out there. And again, reflecting on the conversation that we had with the HIN at the last meeting, you know, where may they come in to help us be a more selective and intelligent customer. We know there is more that we can go at in relation to productivity and efficiency. We come together, we share best practice, we reference model hospital, GIRFT, etc. But there is definitely more that we can do in that space. And we're seeing, you know, from my perspective, I chair the outpatient transformation board. We know there is progress that we're making, but further still that we could go. And in a similar vein, we also need to think about how we're using our assets and infrastructure to the best of our ability. And an example of that is that the GESH group are currently developing their surgical strategy. Kingston Hospital, who it's probably most pertinent to given geography, in parallel is developing its surgical strategy, so the two will be aligned. So where it makes sense for us to work together within the APC, we are doing so, not just from a productivity and efficiency perspective, but also if we're talking about transforming and changing how we may do things. And then clearly there is more that we need to keep doing in relation to being proactive around identifying and then tackling inequality wherever it may lie. So I think we're in the foothills of that within the APC. You've heard a bit about it, but there is further for us to go at.
Thank you for that, Susan and Joe. I think really encouraging update. You know, it is worth remembering that our elective performance in southwest London is not just the best in London, it is amongst the best in the country. And yes, there are still lengthy waits within that, but the number of our population waiting is much smaller. And we will be bringing our operating plan to this board with our trajectories for future performance in that area in May. So really good to see the community diagnostic centres, and again, that performance is really significant, accounting for 50% of London's activities. Patient portal, really exciting to see that operating at such a well, every time I see Joe Harrison or hear Joe Harrison speak at a national event, and he's the lead for the NHS app, the national lead for the NHS app, he signals out South West London as being in the forefront of implementing and using the NHS app. Probably also worth saying a big thank you to Joe. Kingston is the best performing trust again in London in relation to the PIFU pathway, and other people are seeking to learn from Kingston in that space. So some really good things. Really pleased to see ambient IA being operated again by Kingston, but also at St George's now. I anticipate that we will be having a discussion on that, particularly in relation to how we can support its adoption in primary care over the course of the calendar year ahead. I'm going to take a few comments. So I think, Omar, you had your hand up right at the beginning of this. I'll ask people to, on the basis we need to take a break shortly, I'll ask people to be relatively brief, but I will come round to people. So, Omar.
Thank you. That was fantastic, and I very much look forward to touching base with you outside of the session. I'm interested. So the work's great. I mean, I'm very interested in kind of what the business case looks like and what the ROI looks like, and then kind of the next step of the operationalizing this makes an impact, and then how does that land in the bottom line? Like, how does it fit together? That's very interesting. Not necessarily for now, but that was something I'm interested in.
So I'll say I'll take a few points. If I could go to Jonathan next.
Just to say thank you very much for a great presentation, really clear and comprehensive, and shows the breadth of what the APC is doing. So thank you for that. Really appreciate that. It is there in the slides, and you talked about it as well. But the focus on efficiency, given what we might expect to emerge through the planning guidance, is going to be even more apposite than perhaps it has been in the past. And again, it will come as a surprise to neither Susan or Joe to say this, but given the collective investment we make in clinical networks, how we use the transformation skills and capacity of the clinicians there to drive, you touched on two areas, but there are other areas like ophthalmology and ENT that we're focused on where we really need to get to a place of being able to articulate what they're going to deliver in productivity terms. So that would be my addition, but thank you. And you can see the momentum over the last year.
Really good. Sarah.
Hi, thank you very much for the presentation. I would be very interested in knowing how you see the voluntary sector sitting within the providers collaborative. We've got some amazing hospices, across the system, both for children and adults, but also alongside the providers collaborative, because I'm sure you do work with quite a lot of voluntary sector groups when it comes to discharge.
Great, thank you. Annette?
Thank you, Susan and Joe. Really great presentation and really good to hear how this is all coming along. A lot of what you talked about is about putting control back in patients' hands, and I think we get, as a GP in Kingston, we get a lot of positive comments about the patient portal and about the PIFU, so I think just really positive there. I wanted to ask two questions and then make one last comment was, do we have a go live date for the direct access from primary care to investigations? I think this would be a huge step forward, would really help our patients, but also help to increase efficiency within the outpatient clinics in hospitals. And can we roll out the Get You Better app to consultants as well, please? I think, there are a lot of patients who would benefit, and it's a simple thing for them to be able to do in their outpatient clinics, and I think that would have benefits for primary care again. And then lastly was, so if we look at the benefits that we get in our triage system, we run a total triage system in our practice where patients fill in a questionnaire, and then we can assess what would be the best treatment option for them, whether that's an appointment or referral on elsewhere or signposting. I can only imagine that the pre-appointment questionnaires in the hospital will be similarly revealing and help enormously with you directing your capacity and clinical input to where it would be best put, shall we say.
Fantastic. I'm going to take three more, and I know who they are already. So I'll take Elisa, Masood, and James, and that will be, and then Sarah and Joe will ask you to conclude. Susan, rather, and Joe.
Thanks again for your presentation. Just a quick point regarding digital exclusion. So I know you said that there will be alternative pathways for people who are digitally excluded and disabled. And I just wanted to highlight that there are many people who are disabled who are quite digitally literate. Yes. And so it's really important to test apps with them just to make sure that's as accessible as possible. The other thing I wanted to mention, just to follow up with Annette's comment, I would be quite curious to know what you're doing already in terms of engaging with patients to set your priorities.
Thank you. So, Masood.
Thank you for that, and really good to see that you've got additional support for those that struggle with access. So a key thing sometimes forgotten. I wanted to talk a little bit about the data analytics part, and you said the way in which data analytics are being used to look at the waiting list in order to ensure that there isn't inequity. But what does that look like from the health inequalities perspective and sort of the service users' demographics?
And James.
I think building on that last point, I mean, I'm very close to a lot of this work, and I think we've made fantastic progress. Looking at the government's elected plan and the ambitions, there is something for me about the transition we now have to make from what I think so far has been largely coalitions of the willing to completely whole-scale change across many pathways and completely comprehensively, so all the patients on a pathway, and the implications that has not just for the acute provider collaborative, but also for all of the partners across the pathway, in particular primary care, where we know there are really significant challenges around workload, and there are potential consequences of some of these pathway changes in terms of what we're asking primary care colleagues to do. So I'm just interested for your thoughts about how we really mobilise the whole system, and as a place leader, how we manage to do that both at a system and a place level, with everyone sort of moving together as well.
Really, really helpful set of comments. And actually on Masood's point, I'm not sure if you're aware of Cheshire and Merseyside's initiative around waiting lists, but the piece of technology they're now using for analytics of waiting lists is really driving a step change in the health inequalities approach. Susan and Joe, do you want to sort of briefly summarise rather than answer all of those points?
So just on ROI around tech, I think what we are very much looking to do is make sure that we're very clear on the problem statement, and effectively tech is sitting in two buckets. One is using what we've got and stop sort of magpieing around, picking up more bits, so really standardising the use of the portal, and then understanding where technology will really make a difference and understanding what that hypothesis is at the beginning so that we get the ROI out, because otherwise we don't create dramatic enough change for patient experience, really. And that's something we're very much working on with a piece of work that the chief execs have just asked for, that's really looking at what we have now, what we are implementing and what we need to try and get that. So very keen to speak to you about how we can make that better. In terms of direct access, we have some pathways that are live now, such as new onset diabetes. I think there's two things we're really thinking through. One is thoughtfully introducing ones really based on evidence, and then making sure they're very well circulated and everyone's actually using them. So one of the audits we want to do is check people are actually able to use that and know about it. And then secondly, really think about common pathways where this could make a big difference. In terms of, and I think you're absolutely right, I think the stuff that will be raised through pre-appointment will be utterly different. I think your point is very well made about digital excluded and not having assumptions about who those people might be, because actually for many people it's much easier to do something on the phone than it would be to take time to have an appointment and so on. And so we need to make sure we're not creating separate inequalities by trying to help, if you know what I mean. In terms of the waiting list by inequality, the work we've done so far is looking at a couple of our key pathways. I think what we can see is that where we have contracts in place, where we have a sort of any qualified provider piece, we know that they are, and the IS sector is doing it, they tend to be used by people in less deprived areas. We've now started this entire waiting list initiative, and the comparator we're going to make is the percentage of the people on the waiting list compared to that population size, to make sure that it's really representative of the population at large. I think in terms of the points made about engaging with patients and voluntary sector, that's something that I think we need to do more of. So, and Charlotte does a huge amount of work with the ICS, and we very successfully harnessed that in the Cancer Alliance, and I think we'll do something similar to make sure we don't duplicate in the APC. I think what is also worth noting is that both all of the place teams have very good links, and we're not seeking to replicate or confuse those. Joe, is there anything you want?
Yeah, I mean, I think just a couple of other bits. Just again on the inequalities bit, Masood, we're also looking at a few tools we're sort of evaluating at the moment. That you can apply to wait. We're looking at an outpatient context, but you can apply to a wait list and weight particular characteristics more heavily than others, which might bring people forward on the wait list appropriately. So, in order to tackle inequalities, and I think that's similar to the approach that you've referred to. Mike. And then, yeah, James, I couldn't agree more. We need a bit of a fundamental review here, don't we? We're certainly locally across Kingston, Richmond, looking at the portfolio of services that we deliver, whether it's within the acute setting or in the community too. You know, we're now benefiting from being in a sort of vertical arrangement, but I think we need to be really clear who's doing what, where the work is happening, and that cuts across what we're doing across the APC, but equally it cuts across where work is done both within a hospital, outside, within the community, and closer to home, which I know is all part of the long, you know, the 10-year planning process, but that's the territory that we're in now. So I agree, we need to do a sort of proper piece of work around all of that.
Thank you very much for what I think was a really rich presentation, and it's just great to see all of that work underway. We're now going to take a 10-minute break, so if people could rejoin this meeting by 25:02, please. Okay, I'm going to ask everybody if they can retake their seats, and we'll start the meeting. Okay, we'll restart the meeting. So thank you for that. We're going to move on to item 6 on the agenda, which is the delegation of specialised services to South West London ICB. So Jonathan and Martin are going to present this. I'm not sure. Are you leading on this, Martin?
It's a double act, Chair. So and for those who don't know, Martin runs the South London Office of Specialised Services, so he's very grateful that he's able to join us and be with us today. This is really alerting to the board to the movement towards delegation of specialised services across London, so it's across the whole of the capital and indeed across South West London. We're joining the rest of the country, or many other parts of the country that took delegation last April, and we did share with board members in quite an extensive briefing on this topic last month. So we have given this some considerable airing on the issues a month ago. So this is really the formal element of it, the formal decision making. So just so we're clear what we're asking for authorisation for the Chief Executive to sign the delegation agreement with NHS England from April 25, and also the collaboration arrangement and agreement about how we're going to work across the system. So those are the sort of formal asks. So just by a bit of way of context for colleagues, specialised services have previously been commissioned by NHS England for more than a decade now. And we have been working together for the last 3 years, together with colleagues in South East London, to sort of lead the way in thinking about how we're going to make delegation of specialised services work, and hence setting up the South London Office of Specialised Services that Martin leads, and the Pathfinder that was around as part of that to share learning and experience. So we have a track record in trying to understand the issues that we face as we take on this challenge around specialised services commissioning. The paper does set out the case for change, so there are clear benefits in terms of joining up the pathway, end-to-end pathway care. There are real health inequality issues across the specialised and non-specialised pathways, and there's also some opportunity to drive value by joining these pathways up again. You can see in the paper under section 3.3 4 of the programmes that we did talk in some detail through the December briefing of how we've done things in a joined up way and how we've used resources effectively. And just to give 2 examples of those 4 examples, the work that we've done on bloodborne viruses, so identifying people with HIV, hepatitis B and C, and the number of new diagnoses found through the work that we've been doing together is an illustration of how we can work together on end-to-end pathways. And a real focus on sickle cell disease, which has been a long under-focused area on in the NHS. And, for example, getting in place the bypass unit at St George's, so people who are in crisis with sickle cell are able to get access to more timely care more quickly. That was established last autumn, is another example of it. So there are significant opportunities. There's been, as the paper sets out, extensive work on the future operating model and how that's going to be in place, both within South West London, across South London and across London, and the paper sets out some issues on that. They include the role of the Specialised Services Shared Commissioning Team, which is currently a team managed by NHS England across London, and the concerns I've previously raised are still there, really, about the resourcing that we're going to receive in order to do what we need to do. So that remains a significant area of risk. This does include mental health services as well as acute services, as set out in the paper. It isn't all specialised services. There's about 20% of specialised service spend that will not be delegated and will be retained by NHS England. The paper talks through the governance arrangements at ICB and multi-ICB level, and we also talk about the finances and some of the financial issues, including the risks associated with that as we move towards needs-based allocations. Previously, we talked length about risk, and I think that's really important to note. The risks, we have very little choice about taking on delegation, and I've outlined some of the benefits, but it's also important to outline the risks. So there's significant financial risk as we understand some of the allocations and some of the issues associated with that. There's the issue I've already alluded to around the shared services commissioning resource and how that's deployed across the ICB's, NHS England London, and indeed into South East region and East of England region. That is a significant cause of concern of, will we have the right people and the number of people we need to do this well, and also the risks around some services, so where decisions have been made to invest in particular aspects of services, but not all the financial consequences of that may be thought through. So example of that would be NHS England agreeing to fund additional ITU bedded capacity at one of our trusts for specialised services patients, but funding the capital but not the revenue elements associated with that, and that being a significant issue as we move forward. So hopefully, as this paper, building on the broader conversation we had in December, gives a sense of the opportunity but also the risks posed, and outlines the required ask around sign off of the delegation agreement and the collaboration agreement. So that's my take on what's set out. Martin, do you want to say what I've missed?
No, thank you, Jonathan. No, I don't think you've missed anything. Happy to answer questions on any details, really, particularly around the transformational work, which I think has been exciting and ahead of the curve in terms of other areas, which we're really proud of in South London.
Thank you for that, and I think it is worth talking about that transformational, or noting that transformational work that's been done. Really, really impressive in terms of looking at the pathways and actually shifting the left shift back for many of those specialist services. Sarah, I'm not sure if you wanted to say anything because you are the ICB lead in London in this area.
So yeah, I do think sometimes we do get bogged down in the risks associated with this, and I'm not trying to undermine the fact that there are risks, but there are huge opportunities in this by joining back up the pathway, and we have proved that in South London with the work that we've done on the transformation. It's hugely technically difficult around the relationships working across both South East region, across London, and across numbers of ICBs, particularly as everyone acknowledges the risks that we're all taking on and trying to get the best outcome for everyone. Funding in particular, I think, and resource to support has been a highlight that we've talked about across London, which we'll still need to work through. So I think the delegation, that decision has been made by NHS England. They signed that off in their board a couple of months ago. But I think the detail of some of the allocations, how those allocations will work, how we will split that across London, and how we will look at people moving towards their target, whereas in London we're all considered to be overfunded for specialised services. Trying to kind of work that through over a period of time is something that we're doing at a London level. But I do think, let's not forget, because all of that stuff is really difficult, but let's not forget the huge opportunity that also sits within this.
Thank you for that. And please, the board do recall that back in 2023, we did discuss specialised commissioning and we sought delegation at that point. So we, before it was mandated that we had to take delegation, we sought it earlier. So this is a bit of closing that loop on a conversation from 15, 18 months ago. Callie.
Thanks, Chair. I normally focus on opportunity, but I am going to focus on concerns and risks as a specialised services member, if that's okay. So this is going to happen, decision made. So I'm not suggesting we don't approve the delegation request that's in the paper today. But I do think it's the beginning of a conversation, not the end of the conversation. And the reason for that are two things. First of all, just the point that I think Jonathan and Sarah have just touched on, trying to sort out a reconciliation is really important. The National Specialised Services budget has always been significantly overspent. And that devolution, you know, you can get productivity gains and pathway gains through devolution, but that doesn't happen overnight, as we know. So I am worried for our ICB about the impact there's going to be as we try and get more productive and improve those pathways. So I think the first thing is to really try and sort out the sort of reconciliation between the specialised service provision, what we currently enjoy and what we think is going to hit us. It's risky. I mean, it just is. And there's a lot of risk financially before you get the opportunity gains, which will take a while to pull off, I suspect. I think the second thing, just as a specialised service member, and particularly with my cancer hat on, is just how we manage service developments. Now, I know, you know, there's a basic thing about the bottom line and the devolved budget, but it's very important we continue to innovate for patient benefit, you know, improve survival, as well as improve productivity for the NHS. And that often means thinking about service development funding and prioritising that. And I'm not quite sure how that's going to work in this context. So I'm really glad there's a group, I know, with Jonathan. I think Susan's part of it. There's a group that's looking at all these issues to make sure we can have a functional position with as much risk mitigation as possible while we try and manage this, because it's a very, very difficult shift. I normally say everything's easy and an opportunity, but I think this is really quite tricky to pull off. So I think my key thing was just to express concern about those 2 points, to say that I'm very glad there's a group with Jonathan just looking at this reconciliation issue and the SDF issue, and just to say I think that has to that has to come back to the board. So I'm not suggesting we hold anything up, but that we need to sort out those principles to make sure we've got a flight path that we can manage as an ICB. Thank you.
Worth probably recalling that we still carry debt from London Specialised Commissioning from more than a decade ago. Yeah, it is worth bearing that in mind. Vanessa, I think I saw your hand up.
Yeah, so like Callie, I support the paper. It's clear on governance arrangements. I suppose my question is a little bit about what type of commissioners do we want to be when we take this delegation, right? Are we going to be transactional, directive, micromanaging, for want of a better word, or are we going to allow the provider collaboratives to grow and flourish within that as we set this up, because they're not one or the other, but it's a key moment, isn't it? The beginning parts of this relationship are key, particularly when some of the delegation has already been received by South London Partnership from a mental health perspective. So how are we going to do that well together?
Thank you. And Sarah.
My thought was, since we're talking about specialised services, we are talking about expert patients. These are patients that come with a lot of expertise of their own, well-being and their own journey. Within the budget that has been passed down, is there a line, a resource for engagement of these patients?
Thank you for that. So, Martin and Jonathan, do you want to pick up on any of those points?
Yeah, very, very happy to. The challenge, and Callie's articulated very clearly, I feel that very acutely too. I think it is a significant challenge. It's one of those areas where it's very easy to spend multiple millions of pounds on patients that you weren't expecting to, and therefore the financial reconciliation is really important. I think there's quite a way to go still with London to get some of that right in terms of the resourcing that sits around it, as well as the specific numbers that are aligned to particular schedules of income. And there's some sort of collective reflection, I think, as in ICBs, and collectively we need as ICBs about what the priorities are for investment in specialised services going forward. One that will be close to many of us in the room is the changes around the PTC and POSCU designation, and how we support some of that as in the paediatric oncology share care and primary treatment centre work for children. So those two elements are really important. So really, really key. So completely endorse that. To Vanessa's challenge about how we're going to do this. So there's something about doing this safely, to the thrust of what we've been talking about. That is a significant concern early on, but also to what Sarah and I were saying earlier about there are opportunities here, and we need to think about what those opportunities are and focus our resource. But it doesn't make sense to patients, does it, that there's different commissioners of these services? So we need. So I welcome the rejoining of them for that reason, and I think we need to work out with our 3 provider collaboratives whether we all understand the risk in terms of safety, and by that I mean quality of service as well as financial impact. So I think there's a lot to work through, I suppose, and it's almost Callie's point about it's the start of a conversation as we take this forward. And then to Sarah's comment about engagement, then I think there are 43 clinical networks around specialised services, so you're quite right. There are a lot of real expert users in this area, and we need to think about how we make the most of that expertise, and that's probably a challenge that through the South London office and through the ICB, we need to reflect on more, and maybe we can draw on your expertise about how we might do that, share what those networks are, and think about how we make most of those expert users who are actually very vocal and very influential in those clinical networks, how we build that into some of how we design, how we want to commission these services going forward. So those are my reflections on the points. I don't know, again, Martin, whether there's something you want.
I guess just to Vanessa's point about collaboration, I guess the South London office has been a collaboration across South London. I think there are discussions going on around mental health between South East London and South West London. I think Lucy's involved in those conversations, and I don't think it's about micromanagement. I think it is about transformation, the opportunities across the system, and working on roles and responsibilities in a way that draws on the provider assets and expertise, as well as linking things like the cancer alliances and other vehicles that we have across our system. So I would just add that as well around mental health.
Aware.
Yeah.
I'll give some final words to Sarah on this.
So I agree with everything that everyone has said. What I would say is it's absolutely right. This is the start of a process. We still haven't sorted out absolutely the allocations, what that means, how that will work. It's important that we learn from the past. There are risks around this, but what we're trying to do in South London is to build the relationships at a London level, working with South East, working with our partner ICBs, and working with providers. It's important that the opportunities we do take advantage of, and that we allow the freedom for people to actually develop and do the right thing for local people. And I think that that's the opportunity that we need to make the most of, but not underestimating the risk, but learning from the past. So I do think it is the start of that process. So even though we're taking the delegation from the 1st of April, we're not going to have a full-scale change on the 1st of April. What we will have to do is work through with everyone, how do we keep this safe? How do we make sure that it delivers the opportunities, but also manages the risks? So I think we are where we are on this. There could be some really good opportunities here that help our local people, but let's not underestimate the amount of work that we still have to do, I think, would be the bottom line.
Thank you. So we're authorising the Chief Executive to sign the delegation agreement with NHS England before April 2025, and we note the collaboration agreement with all London ICBs and NHS England and its underpinning host ICB agreements, whenever that is decided, will be brought for executive signature as well. Thank you for that. Martin, thank you for joining us. We'll now move on to agenda item 7, which is the intensive and assertive community mental health services. And Lucy is going to join us as well. So Karen and Lucy, over to you.
Thank you. This report is brought to the board to note a really important piece of work that's been undertaken across South West London. In the 2024-25 operating guidance, we were asked to review, because of some really unfortunate incidents in other parts of the country, we were asked to review community mental health services to make sure that clear policies were in place for the care and treatment of those patients. That review has been undertaken, and I've asked Lucy to just come with us to share the process, but also the findings of that review for the board to note.
Thank you, Karen. Thank you for inviting me to board. It's really nice to see some colleagues and at least 2 previous bosses in the room. So for those who don't know me, I'm Lucy Waters. I am the Director of Integration for South West London. And that means I cover all the health and care in the community services, so primary care, community services, mental health, learning disability, care homes and end-of-life care. But more than that, it's the work that we do to integrate services around our frail, complex and often older people in the community. And in that respect, I think I'm reasonably well placed to talk about the complexity of this patient group and the work that we have done. As Karen said, this is for the board to note, so what I'm going to do is summarise this in fairly short order, but I will describe the patient group, the ask that was made in the guidance, the process that we went through, the outcome, and then the next steps. I might ask John to comment because he is obviously he was part of our process in case there's anything he wants to add that I've missed when I get to the end. So in terms of the patient group, it is set out here, but it is predominantly intensive and assertive community outreach services are aimed at people who present with psychosis, who may not respond to routine monitoring or may even be avoidant to routine monitoring, support and treatment, and are therefore vulnerable to relapse with serious associated harms, have multiple social needs and co-occurring problems, may indeed have had negative experiences of mental health services in the past, which of course triggers those that reluctance and avoidant behaviours with mental health services, and where concerns have been raised by family and carers. The expectation that came from the guidance was that the ICBs would work with its mental health provider trusts, and obviously for us that's South West London St George's for 5 of our boroughs and South London and Maudsley for Croydon, to ensure that the governance, partnership working arrangements and systems were in place that identified and then provided appropriate services to people within that cohort. Above and beyond that, there was a very specific ask that DNAs, do not attend, were never used as a reason for discharge from care for this vulnerable patient group. And that was obviously something that we looked at during our assessment process. So the ask went to both trusts that underwent an internal rigorous self-assessment process that was also assured by their boards, and then came to us as the ICB to do assurance of the self-assessments that the Trust had undertaken. As it says in the paper, that we had a meeting in September where John, as CMO, myself as the director lead, and another place lead who had significant mental health experience, met with exec leads from the Trust and went through an assessment process of their due diligence, what they had done, and then a very frank and open conversation about the risks that there are for caring for a very complex cohort in the community. And the place that we got to was a place of assurance that the services and the governance and the frameworks are in place, but that assurance has a caveat with it. This is not a patient group with any set of services that you could always say there will never be an incident because of, you know, the considerable complexity and the need to work with each individual in each borough in a very specific way to try and address their needs and try and ensure that they are they can be engaged with treatment on an ongoing basis. Having submitted that to NHS England, we also identified the range of risks that we thought sat alongside our assurance, and have then undergone a piece of work that looks at how we might mitigate those risks. And some of those risks related to bed availability, workforce initiatives, and not just about capacity, but as we said, about the importance of relationship building with individuals and with very complex conditions in each of the boroughs. The forensic interface, so people who don't actually have a forensic order but have had engagement with forensic services, and unwarranted variation between boroughs, because as with any set of services, some are achieving more than others in this service. So that's an ongoing conversation with NHS England. We have costed some plans that we will be looking at for implementation next year, dependent on the guidance that we get and how NHS England prioritises this in the way they direct mental health investment for 25-26. So I'll now ask John if there's anything he'd like to add about the process we went through.
So, thank you, Lucy. So, look, just to say, healthcare is a risky business. So whether you're a GP diagnosing a sore throat and deciding that a young child doesn't have meningitis, whether you're somebody working in an ED department deciding that chest pain is musculoskeletal and not cardiac, or whether you're somebody working in the mental health community with a service user who is unwell and you're trying to ascertain whether they are a risk to themselves or to somebody else, is difficult, is tricky. You need to have policies, you need to have procedures, you need to have the right training. And even with all of those things in place, irrespective of the healthcare setting, you sometimes just need an element of luck. And so good people will make the right decisions in that context, and it'll subsequently turn out to be wrong. So I think we just need to understand that diagnosis in healthcare, particularly in mental health care, when you're assessing risk, is tricky because risk is dynamic and it changes depending on the context and the circumstances. We were assured from listening to the providers that simple things, that not using DNAs in particular as a reason to not follow people up, were recognised as being not good practice, and they weren't doing that, which was assuring. We had helpful conversations, particularly around safeguarding, because we missed the opportunities in terms of safeguarding. So we always think our people focusing on people being a risk to other people, but not necessarily within the family context. And just to reassure people who might be listening is that mental health patients do not necessarily present a risk to them, particularly when they're unwell. So we must avoid that stigmatisation, which unfortunately has developed in understandable response to some of the horrific incidents, particularly in Nottingham. So that doesn't mean to say there isn't lots to learn. When things do go wrong in healthcare, whether it's mental health or physical health, it's normally down to communication. So I think the one thing we need to continue to reiterate to our colleagues is a failure to either ask the question of colleagues or tell colleagues when there is an escalating risk is when we look back at these incidents as some of the root causes. So if we focus on the basics of communication and skills, we'll probably get further along the journey to making things as safe as humanly possible. It's important also that we reflect within the mental health care spaces that we don't return to the bad old days of restrictive practices, and that we take a positive approach to risk management so that we can support people to live independent lives in the communities. Because we spent generations closing down asylums because they were not a good way to deliver health services in the community. So we need to avoid the risk that we don't start this whole sort of period going forward of sort of restricting people in their lives, whether that's in the healthcare space or, dare I say it, in a prison space, because that's not where we want to be. But notwithstanding that, just acknowledging the impact on victims, families and carers of when something does go wrong in a healthcare setting. So there's a balance to be struck here. I think the providers are doing the best that they can, but there's always more that we can do, and we need to learn from when things go wrong. So that's my thoughts on the chair.
Thank you for a really thorough report. Thank you for a really well presented. I don't know if anybody would like to say anything. Vanessa, I'm assuming that you would.
Yeah, I feel like I should. So yeah, thank you actually, Lucy and John. The process has been really supportive and really challenging in the right way, which is how it should be. We're looking after some of the most vulnerable people in society. And within the risk factors here that we list, service capacity is listed as a risk factor. And we as an ICS make choices about where we invest resources. And for our most vulnerable population in mental health, for serious mental illness, we have a real service capacity issue. And so I want that noted here, because that carries a risk, and it carries a risk for the individuals, also carries a risk for the staff working with those individuals as well. So whilst we've got an assured position, it is in the real view of serious service capacity challenges, both in terms of our community provision, which I would highlight as being the biggest risk. We spoke earlier at the board about elective recovery and waiting times. I don't think the board has sight of the waiting times in mental health in its fullest sense, has sight of the waiting times for talking therapies for our lowest level, and for ADHD to some extent, but not for our most seriously mentally unwell patients. And perhaps the board would be minded to have a look at what the real picture is within mental health provision and the real capacity challenges that exist. At the same time, we are doing our very best to manage the risk for this vulnerable population.
Vanessa, thank you for that. Elisa.
Thank you for that report. I was wondering if anyone with lived experience was included in the audit, or if they will be included in the development of the action plan that we will be emerging. My other question is whether or not the audit scrutinized whether any of the practices were contributing to health inequalities.
So Vanessa, you might want to take that.
So within the review that we carried out within the trust, we had people with lived experience involved with that, and we looked at it we also looked at it with an ethnicity lens. We could have done more, but we did take. There is a significant disadvantage for people from black and brown communities in this population.
Thank you. So, Hannah, and then we'll move on. Hannah.
Thank you. Just a quick observation, really. Thank you so much for the report, both. Just interested in relation to the engagement levels with local authorities, because I noticed a risk factor that has been issued here is local authority services, including housing. I'm really keen to understand, and I think local authorities across the piece would be keen to understand what's the data sets that sit behind that, and how we help you in relation to that action plan development going forward. Very happy to pick it up outside. Yeah, thank you.
Thank you for that, Hannah. Lucy and John, thank you for that very much. We'll move on to item 8, which is the Integrated Care Partnership update. As the paper notes, we had a meeting on the 4th of December. This report would normally be given by my co-chair of the Integrated Care Partnership, Andreas, but as he is not present today, I'll keep it very brief, just to say that we did look at the mental health and well-being strategy, which focuses upon mental health community interventions. We looked at Connect to Work, which we have discussed today as part of the workforce piece. We had some really interesting presentations from local authorities in terms of preparation around their forthcoming CQC inspections. And we had a lively discussion about the way in which, as a system in South West London, across third sector, local authority and NHS organisations, we could better discharge our responsibilities as anchor organisations, all of which I think will be fed into future ICB board meetings as and when appropriate. I'm happy to take any questions, but I'm assuming that people are content to move on. Thank you. We'll move on to our reports. And the first of those, I'm going to ask Finance and Planning Committee. So first I'll ask Jamal, as chair of that committee, to present a brief update on recent meetings, and then across to Helen for a brief update on finance. Jamal.
Thank you very much indeed, Chair. Yep, so I'll give a brief update on the Finance and Planning Committee the last meeting that we had was on the 17th of December. And I'll share 2 or 3 points, and as Mike identified, Helen will go into a bit more detail. One of the points there, I'll start off with where we are in terms of finances. It's clear to say we remain challenged as an ICS, and to hit our year-end financial deficit of 120 million. Where we sit at the moment, and the last review we did was early on in month 8. We were adverse to plan by 16.9 million, and driven by some of the risks that we're aware of, such as baseline pressures, award shortfalls and industrial action. And the forecast outturn remains in line with the submitted plan, but this will be challenging to deliver, and it does include 32.7 million of unmitigated risks included. One of the areas that we asked in the meeting was to focus in on one of the areas that had the biggest risk, which was St George's, Epsom, St Helier. So we invited Andrew Grimshaw to share with us where their position was. It was a good update from him. Clearly, they're at the moment on a 4.2 million at Epsom, St Helier shortfall to deficit, and St George's 7 million. As some of you will be aware, they instigated an investigation, an intervention diagnostic with Deloitte to come in and have a look at the trust. So we wanted to. It was important for us to understand where they were on that journey of the learnings that had uncovered. I was going to say what the report revealed was actually there was evidence of enhanced and strong controls in the trust. So that was on the positive side, but there was opportunity for shared learnings. We're getting darker and darker in here. Shared learnings, not doom and gloom. Not doom and gloom. There is some upside to this. There were some opportunities for shared learning across the trust, and the 4 or 5 areas that they identified, including medical rostering, additional pay controls, the exec are taking forward and actioning over the next period. So we have some, we've got a bit of action to do to move those areas forward. The other areas that we discussed in the meeting, we looked at really briefly. We had a session on the estates risk review. There clearly is a structure, an infrastructure strategy that was developed in July 24. We just reviewed the risks around that and noted a number of those. One that did come across as quite a big risk area that we need to look at was obviously the void costs across the system, and particularly Queen Mary's Hospital at Roehampton, if people aren't aware of that. We also did a workforce review. It covered many of the things that we heard earlier today, but we also looked at the financial aspects of the workforce review and the challenge around the whole-time equivalent targets that we're working towards. So they were discussed. That was also part of the conversation for the missions board update. So we discussed that in the Finance Planning Committee, and a series of transformation and cost improvement programs were discussed, and action plans were created to move those forward. In conclusion, the ICB business, on a positive note, is on plan to deliver a 3.1 million surplus. And then we also signed off a number of business cases.
Thank you very much. Helen.
Thanks, Jamal. So just to add a bit of flavour to you've described the position there for month 8. We are in an extremely challenging position. We've probably got around a £24 million gap at the moment in where we're going, and that we need to look to close. There is additional guidance coming out shortly and as we speak, and for those that read the HSJ, you might see some of the edited highlights out there as additional challenges are coming out during the year. Within this week it's become to light that ERF is likely to be capped this year, and so therefore there is a risk to providers, whether they be the independent sector or the NHS, around the delivery of activity and being paid elective recovery funds if it exceeds that cap. So we need to work together as a system to understand exactly where we are as a position to be able to manage that through as we go forwards. The key things we're focusing then on is around grip and control, and about how we can make sure we're driving through the savings plans and the efficiencies that we have got planned there, recognising that that ERF income is now capped. As we go forward. So the other part I just wanted to highlight was around capital. We've done a lot of work on the capital plan to review, and although we look behind, actually we're in a very good place now, and we've managed to secure some additional national funds in the last few months to help and support our providers. So I feel confident that we will deliver that plan.
Excellent, thank you. Any questions for Jamal or Helen in relation to finances? Thank you. We'll move on to quality and performance. If I can go to Masood now, who's the chair of our Quality and Performance and Oversight Committee. Masood.
Thank you, Chair. So I'll cover a few key points and really, thank you. I'll cover a few points and really start with a thank you to Mercy, who chaired the meeting on the 11th of December. In terms of the risk register, there were 3 additional risks, 2 that were escalated from place to the board related to safeguarding, and 1 was reinstated as a risk regarding learning from deaths review and the backlog, and that's been moved to the corporate risk register. However, I'd like to provide some assurance that additional resources have been allocated. From a performance perspective, some of the key challenges: we have 166 patients still waiting over 65 weeks. However, this is the lowest in London. And we also have 159 mental health A&E 12-hour breaches in September, and that's the highest it's been in 12 months. Some of the good news is that actually from 6-in-1 childhood immunisation uptake, that's perspective, that's increased to 89.1%, which is above the London average. We've got 100% compliance relating to urgent eating disorder cases seen within a week. Touching upon some of the work we've done in the mental health space, our early intervention psychosis performance has been the highest it's been for 12 months, and our acute length of stay over 21 days has dropped to 727, which is the lowest in 10 months. We do have a couple of areas still of concern, major concern. One is around the A&E breaches in mental health, which I've touched upon, and efforts are underway to address the discharge processes and improve the hospital flow. But also the paediatric elective recovery. Those waiting lists have actually been worsening post-pandemic with ENT and dermatology, some areas of concern. From a quality perspective, we've noted that LAS safety concerns related to hospital handover delays are evident, and there is a national paediatric audiology review underway with aiming for reassessments by March 2025. There's also been some interesting work around the management of interstitial lung disease with actions including patient notifications and safety reviews. A number of annual reports were noted by the committee, including safeguarding, learning from death review and evidence-based intervention, and a quality and performance work plan for 2024 to 25 was reviewed. That's it, Chair.
Masood, thank you for that. Probably worth remembering, we normally talk about having 2 mental health providers. We actually have 3 if we include Epsom, which of course isn't in London, but is covered by South West London, and it is served by Surrey and Borders, and a significant number of those A&E breaches actually relate to Epsom and Surrey and Borders. So I'm well aware that Sarah's been having extensive conversations, as have others, with our colleagues in Surrey. If I can go to Elaine for the quality report, and then I'll come to you, Jonathan.
Thank you, Chair. I'll take the report as read, just to highlight the paediatric audiology programme has commenced, and we had a very successful visit in Croydon last week, where NHS England colleagues and subject matter expert was really impressed with the improvement work that's happened and the progress that's making. The visits have been planned around need and concern. So there's another visit going on this week. So that programme has started and is making good progress. You'll see from the report where some of the issues that we've talked about, the progress that's being made. So the intestinal lung disease, the update in terms of and the progress that's being made there. CQC colleagues have been busy on the patch. They are still on the patch and are not quite ready to leave our patch at the moment. We are sharing lessons learned across South West London from some of those inspections and visits and concerns. There's a piece of work tomorrow with the CNOs around some of that as well. You can see where South West London are learning from some of the Never events. You'll see where we've had a number of Never events, and we're just going back over the themes and the actions and learning from those. We continue to do well with PSURF. We've started our learning review visits again, had some successful learning review visits and sharing that learning, and continue to work on our inequalities around some of our incidents. IPC has been a particular challenge across South West London. It's been a particular challenge generally across the country, but a challenge, as people will have seen in the local media, in terms of flu, norovirus, COVID and RSV, and our trusts have managed exceptionally well given those challenges and continue to learn from that. Happy to take any questions.
Thank you, Elaine. Jonathan.
Thank you very much. I'll take the report as read, and just three comments, all of which have been touched on at some point in the meeting. But just to your point about mental health, we've made significant progress with our two host mental health providers since some of the data that was in the report, but remain challenged out of sector with Surrey and Borders, particularly, and there's a lot of intensive work going on in that space. To just what Elaine has been talking about, the pressure on our emergency departments, and I know we've talked about that earlier in this meeting, and how very challenging and difficult that has been. And I think we rightly acknowledge that for staff and for patients. Having said that, our performance against people in the community, for example, who have strokes, and timely access to ambulances remains good and the best in London, and London is the best performing region against the 4-hour standard, and St George's is the sort of outstanding area of progress over the last 12 months against that. So there are some positives in a very, very difficult and challenged environment. And Susan earlier talked about our elective position and gave the latest update on that, so I won't repeat that, but also note in the context of the financial challenges and what the elective recovery fund may look like into the future, this is going to be a really difficult space for us into 25-26. So those are three reflections. If there are comments people want to make on the report or questions, obviously very happy to take those too.
Thank you. We'll move on, and we'll move on to item 10. So we'll move on to the Chief Executive's report.
Thank you very much, Chair. So firstly, I'm not going to repeat because you've talked about a lot of the areas that are on my report. I'll just point out the publication of the plan for elective care, which we did discuss earlier, but what I would reiterate is that we still await the operating plan, and actually, even though we have a plan for elective care, there's a lot of question marks still about how we will fund that, how it will work, and we are still awaiting that. So we will give you a further update when we receive that, which may be this week, it may be next week, or it may be even longer, but that we are expecting to get it imminently. But it's very important for us that it's not just about the elective plan, it will be our financial position and and everything else. So we are still awaiting that. And if I can just take a moment, because it is my last meeting, firstly, I just wanted to say thank you for the flowers. That is lovely. Thank you very much. But actually, I should be saying thank you to you, because you are a fantastic team in South West London. It's a privilege for me to have worked in South West London. And I would say there's 3 areas actually where South West London is unique and is part of why I wanted and still want to work, and work with you in the future at some point in another role, or maybe as a resident, because I might come in and start giving you my views. Wouldn't you all love that? Start turning up to your meetings and telling you what I think of your services in public. You're going to love me. But there's 3 things that are unique about South West London. Firstly is we actually deliver really well in South West London. That's come through, I think, in everything that we've talked about today. Cancer, elective recovery, our primary care is fantastic, community services, mental health, we are doing really well. And also the work that we do to engage with everyone and to take people with us. So, we do a fantastic job on delivery in South West London. The second thing we do well, I think, and it is difficult to do, is to get that balance between place and South West London and how we work together. And I think that we have good relationships with our local authorities, with our partners, with the voluntary sector, with everybody that works with us in the system. And then the third bit is the partnership, because we have partnerships that are across the NHS, but not just across the NHS, they're across all of the organisations and our general public in South West London. And these are not always successful, all of these things that I mentioned, in all areas. And in South West London, we do this really well. So I hope that you will continue to do this really well, particularly as I will be coming to your boards and telling you what I think of your services. But because actually it's for the benefit of everyone in South West London. So thank you all, and thank you for all of your support. Some of you I know more recently, some of you I've known for many years, Nicola, and I've really enjoyed working with all of you, so thank you.
Thank you. Any other business? I've got one item of any other business. John.
Thank you, Chair. Just to say that ourselves and the HIN collaborated to submit a bid to the Health Foundation, who are running a scheme exploring how ICBs develop their approach to innovation as ecosystems. So we were one of 5 ICBs to be successful. Always good to note that some neighbour colleagues weren't successful, not that we're competitive or boasting in any shape or form, but we'll be more than happy to share our learning with them. On a serious note, though, it does allow us to think and have the space to develop an approach to innovation, perhaps develop a framework, as well as doing some organisational development for the organisation and some wider colleagues as we develop the approach over the next year. So it's a small sum of money, it's well received in difficult times, but I think it'll enable us as a system perhaps to create the conditions to develop a closer working relationship with the Health Foundation, who have been at the forefront of quality and improvement in sort of UK healthcare for the last 15 or 20 years. So a big thank you to our colleagues in the HIN who supported us and our partners in this approach.
John, thank you for alerting us to that. Joe, did I just see your hand go up?
We all want to say something.
Yeah, thank you. If I can just say a massive thank you to Sarah, both sort of personally and for all that she's done for us as sort of chief executives and at a sort of corporate level. Sarah, I'm probably in the category of people that you've known relatively recently compared with how how long and deep some of your relationships are, but I've always found you personally hugely supportive, a great source of advice when there have been the odd bump in the road, and I've had a few of those in recent times. I've never found it difficult to talk to you about the things that I need to talk to you about, which I think is a really important quality in the business that we're in. You've helped us sort of individually and collectively navigate some really difficult times in my time. So if I think about COVID and what's come after that, this is by no means easy territory to be in. And it is clear you're really proud of what we do in South West London, and you help us fly the flag. So just a massive thank you from me.
Well, I think Joe said it all. I think the provider chief execs were just really anxious to add to your thanks at the beginning, Chair, to Sarah for being so collegiate, so measured, so supportive, and I think we all have individually and collectively really benefited from your leadership. Thank you very much from all of us. We really appreciate it. And we'll celebrate outside this room.
I was going to say that there will, of course, be other
Yes.
opportunities for us to say goodbye to Sarah in sort of less formal settings. So I'm going to close the meeting now, and we'll go across to public questions. Wendy, I can see your hands up.
As I often say in these meetings, my name's Wendy Micklewright. I hallucinate, I hear your voices, I'm not ill, I don't take psychiatric drugs. I'm involved with a community group that's affiliated to the Hearing and Voices Network. The Hearing Voices Network practices were recommended by the World Health Organization when they said that the mental health system needs to change radically. And as I've mentioned here before, the World Health Organization and the UN have called to an end to coercive practices within the mental health system. Last time I was here, when we reviewed what I'd said, I think there were two things that I wasn't very clear about. The first thing was I mentioned that there has been a call for a revolution, a participatory revolution, or what I would call people power. The person who raised this issue was Danny Suriskandaraja. Danny is the former CEO of Oxfam. He's the current CEO of New Economic Foundation. Danny spoke about this issue, the need for a participatory revolution. He spoke about this on the BBC's Question Time. He said that only 7% of the people in this country believe that the people in positions of power are acting in their best interest. And there is a problem there. And everyone, I think everyone in this room should think about that, and how there is a lack of trust between people and establishments. And one of the things that Danny suggested was people assemblies or citizens' assemblies. If we relate this to the NHS, it looks like there's good practice actually happening within the NHS. It's to do with cancer prevention and cancer care. They have a citizens' jury, which is the equivalent of a people's assembly. So that's not just calling people in, like experts by experience. It's actually everyone's treated as an equal. If you're not familiar with people's assemblies, I'm sure you can find more information if you need to. And that's citizens' jury shaping cancer policies through experience. So I think we need a citizens' assembly or a people's assembly, and we need to be quite focused. And we need to focus on the fact that the World Health Organization and the UN has called for an end to coercive practices within the mental health system. So we need a people's assembly about this. We need to be very focused about it. And we know what these coercive practices are. It's electric shock treatment or electroconvulsive treatment. It's forced imprisonment, it's forced medication, it's restraint, and it's seclusions. Last time I was here, there was a discussion about the Mental Health Act, the revision of the Mental Health Act. There's two reasons why some of us don't think that's going to work. One of the reasons, well, just to give you some background information, I and many of my friends were involved in the consultation for the revision of the Mental Health Act, and very little of what we said was acted upon or made its way into the paper that was presented. John Pringle, who wrote in the Disability News Services, said that mental health bill will not stop us being locked up. And he mentioned the social determinants of mental health, which is poverty and housing and homelessness. We know that 80% of people on mental health wards are in fact homeless, according to evidence from Manchester. There's another reason why I'm concerned about how effective the Mental Health Act will be when you compare it to people assemblies and the success of people assemblies. And that's because Senny's Law, we call it Senny's Law, it came about in 2018. Senny's Law came about because Senny Lewis was held down, a face-down restraint by 11 police officers, and he subsequently died. Sadly, the same year that Senny's Law came into being, which was 2018, Kevin Clark experienced the same thing and also died. So we fast forward 6 years after that act came into being. So on the 29th of December 2024, the Observer published a piece, and it was information that was obtained for, using the Freedom of Information Act by the Liberal Democrats. And they found that despite Senny's Law, there is still an alarming rate of face-down restraints on mental health wards. I don't know if any of the people in this room have witnessed face-down restraints, but I have. In the last few years, I've witnessed 2 face-down restraints. They both happened in the streets near where I live, which is Twickenham. On both occasions, the people being restrained were young men of the global majority. On both occasions, there were at least 5 police officers holding them down. On both occasions, I tried to reduce the risk and tried to prevent further escalation of the problem. On both occasions, the people involved thanked me for my participation. On both occasions, I raised complaints with the police, and those complaints, well, one of them is still ongoing a year after the event. So if we move on to electric convulsive treatment or electric shocks treatment, I'm not sure if you're aware of a UN report, A6315175, which was published on the 28th of July 2008. And on page 9, paragraph 40, it says that if you put electric shocks through our bodies without our consent, it is torture. The other point I didn't make clear was that there are 6 MPs who came out on the 11th of March 2013 calling for a ban of electroshock or electroconvulsive treatment, or torture as the UN calls it, and they called for that ban. The MPs involved in that, one was a GP, there were 6 MPs, I can read out the names if you want, but there were 6 MPs who said that it should stop. And I think some of the foundations, which is Derbyshire Health, I think, based on our information obtained by the Freedom of Information Act, they don't do electroconvulsive treatment. So there may be other reasons why they don't do it, but if they don't do it in Derbyshire, I don't see why they should do it in South West London. We know it's sexist.
Wendy, thank you very much. Thank you very much for that. I think colleagues are, it's always useful for colleagues to hear that. I know that some colleagues will be reflecting on that. Charlotte, I know that you were listening carefully to the piece about engagement. Certainly the 10-year plan is making use of citizens' jury type approaches with deliberative inquiries, and we'll be looking at how we might apply those in South West London moving forward. There didn't seem to be a specific question, Wendy, so I think we'll just note the concerns that you raised, and we'll ask our colleagues to reflect upon those. On that basis, I will close the meeting, and thank you all very much for your attendance.